So you've been traveling a lot?
A bit, not so much. I think I might.
Good afternoon, everyone. Welcome. My name is Peggy Clark. I'm the Vice President of Policy Programs at the Aspen Institute and the Executive Director of Aspen Global Health and Development. Welcome to the Aspen Global Health Roundtable series. We are delighted and honored to have today with us Minister Tedros of Ethiopia, who's here in Washington to receive the Rosalynn and Jimmy Carter Humanitarian Award tomorrow. So we'd all just like to maybe take a moment to recognize him for that very good service. Aspen Global Health and Development is one of the newest programs here at the Aspen Institute. Our focus is identifying and promoting breakthrough solutions to global development and bringing them to scale and supporting those efforts. And we have no more strong example of breakthrough innovations than in the living proof of Minister Tedros of Ethiopia, who has really led the way for so many of the most celebrated innovations in global health today. So we'll be talking in some depth about those. We have been working with Ethiopia and Minister Tedros and his senior team for the last 5 years on a project called the Ministerial Leadership Initiative. There's some information about it in your packets. And this was an innovative effort funded by the Bill and Melinda Gates and the Packard Foundations to really go inside of health ministries in 5 countries, Mali, Nepal, Sierra Leone, Senegal, and Ethiopia, to work intensively around strengthening leadership teams around the areas of health financing for equity, reproductive health, and aid effectiveness. And interestingly, it was a competitive process. Ethiopia applied and was one of the countries. And we ended up working with Minister Tedros and his team around a new accountability system so that there was a sight line from the village clinic all the way up to the Ministry of Health. It's this kind of investing in the architecture in the public sector, in some of the developing countries that have the greatest health needs, that we really think is the sustainable way forward. We don't think many health innovations will go to scale without that. And so we're very delighted to have a wonderful group with us today who will be talking about the issue of country ownership, innovations in global health. And we have a wonderful moderator. John Donnelly has been working with the MLI project for 5 years. He's an award-winning reporter from the Boston Globe. He did a really stunning story about maternal mortality, which was quite beautiful. If many of you have not been able to see it, is amazing. He's now a vice president at the Burness Communications, and he will be introducing and leading the group in a conversation today. We're leaving plenty of time for questions and answers, so get your thoughts together. We have a wonderful panel with us today that John will introduce. Thank you very much.
Thank you. First off, a couple of logistical things. If you have any cell phones on, please turn them off. This is being live cast, and tape of the proceeding will be available later on today, and an edited one will be available in a couple of days, so you can go back to it. Another housekeeping thing. I want to thank the organizers of this event, the staff of the MLI. We have here, and you can just raise your hands, with Sarah Lindsay, Jennifer Magalon, Jennifer, Gwen Hopkins, Stephanie Weber, and the director and sort of the heart and soul of MLI, Roseanne Wiseman, unfortunately couldn't make it today. She had a family a funeral, and but she extends her wishes to everyone. You can't. Oh, sorry. Can you hear me better? Same. Is that all right? Okay. So we call this Straight Talk, and we called it that for a good reason. This is intended to be a conversation where we'll have some talk among us for about half an hour, and then we'll open it up for a half hour of questions. And the panelists, we're here because Minister Tedros is here to receive the award from the Carter Center. But we selected these panels with great care because they they are straight talkers. They are very candid in their assessments of what's happening in global health issues today. And I hope we can get at some of the questions that all of you are thinking about, some of the problems that are going on, the challenges that they're being faced. And instead of going through their CVs, their backgrounds, I'd just like to give a couple of personal observations that I've had over the last years and months of the three panelists. Amy Batson, first. Amy is the Deputy Assistant Administrator for Global Health at USAID. And Amy, I actually met just about a month and a half ago. It was at a private dinner for Research America here in Washington. And she gave this talk, and I thought, she's so candid, she's so interesting on message. I wonder what she's like in a public forum. And I found out the next morning, actually. It was at a vaccines event, and she was even more candid. And so I appreciated her very, very much being an ex-journalist and having someone like Amy here. Mark Dybul I've actually known for 7 or 8 years, I would say. And when I was covering PEPFAR. Mark is one of the founders of PEPFAR from the very beginning. In many, many ways, he rose up to be the U.S. Global AIDS Ambassador. But what I remember most about Mark is we were in Addis Ababa, actually, maybe 2004. And PEPFAR had invited me as a journalist to come and actually go to the U.S. government-only meeting. It was kind of a very risky thing to do, in a sense. But it actually showed the confidence that people at PEPFAR had of what they had going. And what I remember from that event more than anything else was actually a dinner that we had in the hotel. Just walked into it, and they invited me to sit down. And Mark's passion and his fluidity on the issues was just stunning to me. And so I watched him over the years, and what I admired about Mark was, number one, was that he often deflected attention from himself. He would always be telling me things like, "You've got to go talk to this person." And so I always valued when I talked to Mark about things. And I also really watched him and valued it, thought the relationships that he developed were really interesting. First of all, in a political, in a sort of difficult, always a difficult political environment in Washington, Mark had relationships on both sides of the aisle. He became very, very close to President Bush, very, very close to Republicans and Democrats in the House and Senate, and very close actually to, and especially close to people in the field, such as Minister Tedros. When we got here today, Minister Tedros said, "Where is my brother?" Meaning Mark. And Mark said the same thing to him. So there's a real closeness among them. Minister Tedros, I've watched from afar for a long time, and I've got to know him a little bit better in the last couple of months. And I was at an event by MLI in Addis Ababa, and it was called the Learning Collaborator Forum. And we brought together people from 5 ministries that MLI works from. And these people are stars in the ministries. They're unbelievable. And some of them are really, they've just had successes. Some of them are battling incredible challenges. It's up and down. And we had 4 days of great discussions. And Minister Tedros came in at the end. And he talked about his vision for country ownership. And so I listened to him, but then I watched all these people I knew very well in the audience. And they were on the edge of their seats. They were whispering to each other. And then when they left, they're all talking about him. So to me, that's one of the highest compliments I can give you, is that your peers see you as a leader. And they want to hear what you have to say. So that's a long introduction, but I just want to get a feeling of a bit of my thoughts about these 3 people besides their CVs. So I'd like to turn to Mark right away and ask Mark about, see if he would tell a story about Minister Tedros.
There are many stories, and I'll tell some of the ones I can say in public. I'll never forget the first time I met the minister, and he wasn't minister then. He was actually Minister of State and had just been brought in. And PEPFAR was just getting started, and I remember just being so stunned by his compassion, passion, knowledge, extreme knowledge, down to the Kabbalah level, and his vision for how Ethiopia could radically change its healthcare. And then I wasn't coordinator at the time. I wasn't the AIDS ambassador at the time. Then our careers kind of developed in step. And when he became minister, he laid out a vision for what PEPFAR should be. It wasn't the U.S. government coming in and saying, this is what we think we should do, or our partners. He laid out a vision for what should be done, how things could get to the community, how HIV could be used to build a platform for improving the health of his people, looking not at a disease, but looking at a woman or a child or a family. And I remember the U.S. government people not liking that so much and actually pushing back on, well, that's not quite how we've done it before. You know, we have our processes, our planning. And I remember talking with him as minister, and it was just so obvious that what we needed to do was turn to the minister and trust him and let him do what he needed to do, because he knows his country, he knows his partners, he knows what his people need. And so we radically changed everything, and they wound up with a country operations plan that looked nothing like anyone else's. And we agreed it was an experiment. Can we do it this way? Is this the right way to do it? And it absolutely was. And he's transformed healthcare using PEPFAR dollars to build a health for people, and creating what is basically the model, I think, for everyone who wants to take that centered approach. And he does it with extraordinary humility. He never wants to talk about himself. He never wants to talk about his thoughts or his vision. It's always about the people of Ethiopia. I've tried to get him to take other jobs outside of Ethiopia, and the answer is always the same. I'm here for my people. I'm here to improve my people, and I'm not leaving Ethiopia. And so I consider him to be, that's one of the few experiences where his absolute compassion, absolute dedication, absolute knowledge down to the Kabbalah level, and incredible vision of how we can transform healthcare, even in constrained environments. It's breathtaking. And I always think about him when I think about Damiso Moyo's book, and Dead Aid. And the thing that bothered me the most in that book, there are a lot of good points, was this notion that African leaders are self-serving kleptomaniacs or just looking for money. And you look at someone like Tedros, and it's just absurd. And what he taught me is that what development is all about has nothing to do with us. What development is all about is supporting people like Tedros, supporting the people in the communities, supporting the individuals to empower them on their health care, and that we're the very junior partner, if even that, supporting them. And Tedros has been one of my teachers, and I thank him for that and for his friendship and for being his brother.
And if I could just build on that, it's very funny to hear Mark talking about how when he came to talk about PEPFAR in Ethiopia, the reaction was actually Minister Tedros already had it mapped out and told the team what it should be. And in fact, in GHI, not just a couple of months ago, we went out and we had a meeting with Minister Tedros, and we all arrived ready to tell him what was GHI and how did it work. And he immediately started the meeting by saying, let me tell you why GHI is important, and let me tell you what it's going to do. And he proceeded to give us the best sort of definition of the value of GHI, how it built on the successes of the past, on PEPFAR and the President's Malaria Initiative and the other development programs that we've been doing, and helped to really increase that more holistic focus on the person and all of their needs, and the focus on sustainability and building the systems that would allow this to be enduring beyond the sort of immediate health gains. And so it's a very similar experience, and Minister Tedros continues to be helping us really define out what this can mean and how it really translates into a country and its national plan, and supporting that country to be achieving its objectives.
So Minister Tedros, I think, is this on?
I think we have it established that you're not shy, but I think a lot of ministers in developing countries are a little shy. What can you tell people who have donors who are very, very strong about what they want to do? What do you tell them in terms of having a vision and standing up for yourself?
Yeah, thank you very much. Thank you, Mark, and thank you, Emmy. I don't know if the audience would trust you because you're my friends, and Mark is my brother. I think it starts with what Mark said. That's what I always say to my colleague partners. Some of them are here in the room, by the way. Just telling again and again, this is our priority, so please help us on this. And then we would even add value, and this is how it's going to help our country. So to really focus on the issue and trying to help them understand our perspective. So this is about negotiation, so we have to try to make sense of what we are saying. And lucky enough, many listen. And I'm actually seeing Susan Anthony here, who was the HPN head in USAID in Ethiopia. And I remember about one negotiation we had with her, a very specific one. I don't know, for people who know Susan Anthony. Would you like to show your face, maybe? Yeah. So as head of the health unit of USAID, we used to do lots of negotiations. And every time we meet, we try to help her understand what's our perspective. As you know, human resource, especially, is one of the major problems in Africa in general and in Ethiopia in particular. And to address the crisis, the human resource crisis, one of the proposals from our government was to go into flooding and retention strategy, to consciously overproduce what we need, and also to install some mechanisms to retain those we have actually trained. And one of the categories we wanted to really fast produce was health officers in Ethiopia. They're equivalent to physician assistants in the US. And the reason for the training of this particular cadre was to staff our new health centers, which we started building, in thousands. And in the last 3 to 4 years, we have already built over 1,900, and we only had 600. So we had to prepare the human resource part of it, and mainly the leaders of these health institutions, the health centers. And it was not in our plan originally, but we had to engage into negotiation with USAID. And the reason was just what I just said. There is a crisis. We need to really fill up this. And this is our solution. And if we do this, we can definitely address the problem. And this is about maternal health. This is about child health. Because we were preparing or building the health centers actually to address the unacceptable rate of maternal mortality in our country, to provide basic obstetric care. And these health officers are going to be key. So that kind of argument will definitely make sense to our partners. And then Susan said, let's go ahead. And that training plan was ambitious. And the number we needed was around 3,200, but our target was 5,000. And we're almost finishing the 5,000 in just a few months from now, at the end of 2011. So this is one of the stories, in addition to what Mark said when I first met him and tried to negotiate on the plans. And I told him that we want to focus on both saving lives and at the same time building our health system. And he wanted to know more. Then we discussed about, when I said new, systems like the information system, about the pharmaceutical finance supply system, about the healthcare finance, especially the health insurance, which we're introducing now, about human resources strategy, as I said, the flooding and retention strategy. So, we tried to offer him, saying we can have more value for the funding that he will give us. We will create more value because we shouldn't just use the money now, saving lives alone, but we need to really start sustaining it. And that's why building on the system while also saving lives is a better idea, because you kill two birds with one stone. And a very good way of also making use of donor money, because not only we're saving lives now, ensuring that, but in addition to that, building the system so we will not always ask for support, but trying to do things to sustain whatever we're doing together, which is, I think, a better way of handling support, and also something that could really develop faith and trust in our partners. So that's what we do. And I can give you another negotiation with Global Fund. Global Fund is also, as you know, vertical, and funds are raised vertically in order to combat HIV, malaria, and TB. But we used exactly the same way as we did with PEPFAR. And we used the Global Fund money also to build the system while saving lives. So I think the whole idea is really focusing on the issue, trying to justify why you want to do things differently, why it makes sense to your country, what you're offering, the value that you're offering. And I think that could really make sense to many of the colleagues I have here when we talk to them. And it's on concrete issues, very specific, and something that could really make sense to all of us. And the additional thing is we try to be on their side also and try to understand their perspective also. And we may not really push beyond a certain limit, because we can understand from their perspective what they can offer and what they can't. Something they can offer, they can give us now, while engaging for the long term. So some of the issues could be corrected then, but some of the issues could take longer time. And as Amy said, for instance, with the Global Health Initiative, that's what we're doing. We have agreed on milestone agreements that can help us build on what we gained on PEPFAR. So I think it's the negotiation, and negotiation in a very positive way, negotiation in a very concrete way, negotiation based on issues, negotiation based on real justifications, and negotiation based on the outcome you would like to have, and showing the country's perspective and the complete vision and how you would like to get there. And people actually get encouraged by that. What do you want to do? What do you want to achieve? And how would you like to do it? And if you know all that, I think that's the first step to trust. Okay, these people know what they're saying, and we can do business, because nobody wants to do business with somebody who doesn't know what to achieve, how to get there. And I'm really glad, and thanks to all colleagues here, and especially Mark and Susan is there, who are really prepared to listen and support based on that. So thank you so much.
But Amy and Mark, is this an exception? Is this how negotiations often go in countries? With GHI, for instance, I'm sure there's a process with the country to go through this. But how much of a change on the fly, it sounds like, what Mr. Tedros is talking about, is being done?
Well, Minister Tedros is very special, as I think we've already established. But in fact, there's a lot of, each country has some very special talents that are driving forward the agenda in different ways. So you have countries like Rwanda, which has a very, very strong sense of what is country ownership. And how then can we help work with them to support building capacity, building more sustainable systems. That country has instituted and really led the way in Africa, I think, for more of a performance-based orientation. So much more focus on how is every dollar invested resulting in concrete health achievements, rather than just the investments in inputs and then the hope that they all ultimately have results. So you have countries like Rwanda who are leading the way in that sphere. You have countries like Nepal, which has a number of really big challenges, but where also the partners are working together on a joint financing agreement under government leadership, so that you're getting clearer, better, and more transparent ways of investing all the partners investing and supporting the government plan of action. So yes, Minister Tedros is definitely special, and it's something it's very exciting to work with him. And I think working with partners like that helps us define how we approach other governments and how we define the work to be more effective and more supportive of country ownership. But there's also other examples, I think, around the world of some really exciting progress.
And I just add to that, I mean, there's no question that Tedros is a very unique and special individual. I think one of the, not just top ministers of health, one of the top people in global health in the world, and so is appropriately being honored tomorrow night. But in every country, there are leaders. Sometimes it's not the minister. Sometimes it's the head of state. Sometimes it's the first lady. Sometimes it's a provincial governor. Sometimes it's a member of parliament. Sometimes it's a non-governmental organization our leader. Sometimes it's a faith leader. And often the most remarkable people are the ones in the villages and the local community that can come up with the most innovative, creative solutions you could possibly think of, and they'll do it for very little money. And one of the remarkable things about what the minister is doing in Ethiopia is allowing that grassroots initiative and innovation to blossom, and then adopting those and growing them nationally. So I really think the one thing we need to learn most is most of the best ideas aren't going to come from here. Most of the best approaches aren't going to come from here. We have to trust and believe in and support the people in the countries. And that's what country ownership is all about. And it's a country. It's not government. It's country. It's government leading, but everyone else engaged, all sectors involved, and everyone pushing in the right direction. And this is happening everywhere. And that's another reason, this book just drives me nuts. I mean, the Africa that's talked about by most people is not the Africa of today. And Africa is a very diverse, it's not a country. It's not even a part of a country. It's a very diverse place. And what's happening there today is among the most exciting, dynamic stuff going on anywhere in the world, not just in health, but in economic growth and microfinance, and it's happening in other parts of the world too. So, we love to pick something and say, oh, this is the example. But that's just because that's what we know. If you have the good fortune to go out and see what's happening out there, it's breathtaking what's happening out there. And our job increasingly has got to be to back down and allow the people who know the countries and know their environments, the people like Minister Tedros, and find them and let them take the ball and run with it. And I think that's what the Global Health Initiative is all about. It's what President Bush tried to do. I mean, he began with the Monterey Consensus, country ownership, results-based development, good governance, and all sectors being involved. As he left, he held a conference on the new era in development with the sessions about those founding principles. Minister Tedros was one of the honored guests. Those sound familiar? The GHI is a natural evolution of those processes. The Millennium Challenge Corporation, PEPFAR, the Director of Foreign Assistance trying to pull it all together. But it all begins with those principles of we need to understand we're not the solution. The Minister Tedroses of the world are the solution. The people in the countries are the solution. We're the facilitator and the supporter, and we need to get out of their way.
I was just going to add that one of the really exciting things that was launched just a little over a week ago is following on Mark's points is how do we put out the challenge and then let the innovators around the world, wherever they may be, at whatever level in the system, from whatever sector they may come from, really rise to that and come up with the ideas. And so we launched the first Grand Challenge for Development. It's going to be a whole series. This one was on saving lives at birth. So how do you really address that critical period when a woman is giving birth, when she and her newborn are at most risk? And throwing out that challenge of saving lives at birth in the rural, poorest countries, and opening it up to everyone. So that challenge has gone out. We will be waiting to sort of see the really exciting sets of proposals that focus on what are the kinds of adaptions of technologies that would improve the supply side, that would improve what a community health worker can take out to the population and improve that health. What about the demand side? How can mobile health help raise awareness, help give more voice to a population? How can you overcome some of the simple barriers that may be limiting a woman's ability to reach out and get the help that she needs? How can you be strengthening that overall system and the reach into it? So it's an exciting shift, exactly what Mark is outlining, of throw out the challenge, but we don't have all the answers. We shouldn't be defining the solutions in advance, and we shouldn't be defining who can solve it. We should be throwing it out and then letting those ideas, those solutions come out and see how we can best support them.
So how do you win congressional support for this vision? I mean, I think we could all agree that that a strong bipartisanship of a couple of years ago with PEPFAR is now in tatters. And so I'd like to know why it's in tatters, and I'd like to know how you're going to build that up again.
Having been in Amy's position before, I'm going to give her a pass on that because it's probably not the best thing in the world for her to try to answer that. I'm actually not sure it's in tatters, but it's frayed. And a couple points on that. And many of the people in the room were around at this time, but a lot of us are forgetting that there was a year-long continuing resolution, I think it was 2007. There was an anomaly for PEPFAR. We got $1 billion increase in the year that there was a year-long continuing resolution. Everyone else in the government was flatlined. If I remember correctly, we were the only increase along with the Department of Defense. Pretty remarkable. And what allowed that to happen was an extraordinary confluence of support. But it began with results-based. It began with being able to say, for this amount of money, this number of lives are going to be lost. The fact of the matter is that we don't, and by respecting the fact that we have budget problems. There's no question we have budget problems. Just going up and saying we need more isn't going to win anyone, whether Democrat, Republican, or anyone else right now, because everyone needs more. You have to be respectful of the fact that there are budgetary situations, but then talk about the fact that there are very few things in the U.S. government's programming envelope of trillions of dollars where you can draw a direct line from dollars to lives saved. And that actually means a lot to members. And that by doing so, the goodwill that's built up towards the United States, the shift in approach, the shift in thinking about the American people is dramatic. The minister might be able to talk about that. Many people in the room can talk about that. I've seen it at the village level. In fact, in Ethiopia, up in Aspen, the birthplace of Christianity in Africa, a beautiful place. We were at a very rural clinic on the outskirts of town, and the head of the clinic, it's a small town, so the head of the clinic is also one of the town elders. We were talking, and he kept saying PEPFAR this and PEPFAR that, and I was in a bad mood and cranky and tired, so I said, well, what does PEPFAR mean? Being a snotty, administrative person, explaining to the President's Emergency Plan for AIDS Relief. He said, PEPFAR means the American people care about us. This is in rural, in a very small part of Ethiopia. That matters a lot to members of both sides of the aisle. And then the national security and global health, and how health and development contribute to economic growth, which leads to markets, which leads to jobs for the American people. I mean, this is not rocket science. I mean, but these arguments need to be made in a way that draws and respects everyone's point of view, and respectful of the budget, but then also talk about what the advantages are and how we can actually, and this was said on the floor of the House by very conservative members and on the Senate when PEPFAR is being reauthorized, we can find places to save money given our vast bureaucracy that isn't going to cost lives. Now, at the same time, we have to be more efficient and effective. A lot of things that GHI and Eric Gooseby, who's an extraordinarily thoughtful and caring man, is working on, are building on some of the things we started to increase efficiency and effectiveness, and we need to do that. We have to show continually how we're saving more and more money. But then we also need to rebuild the bridges. I mean, we did have you call it unholy or holy or just odd alliance of, NGOs interested in global health and HIV/AIDS, the private sector, who were very important, at least in the early going, and the faith-based community. And the faith-based community is not a monolith any more than Africa. There are people from all philosophical perspectives and all political spectrums in there. Just like in the private sector, people think they're all a bunch of Republicans. They're not. There's a huge spectrum there. NGOs tend to be mostly on the Democratic side, but that's okay. But there was this mix of people who said, this matters. And that alliance has frayed. And without that alliance being whole, it's very difficult to hear the voices among the cacophony of other needs. So even when you have these good arguments without that alliance, it's going to be very hard. And where that alliance is frayed is around a sense of not maintaining respect for people's positions. Of course we're going to disagree. I mean, I think the principles of GHI are great, but we're going to disagree on policy. We're supposed to disagree. If everyone thought the same, I'd be really worried. We're supposed to disagree. That's what we're all here to do. We don't know all the answers. We're supposed to disagree with the minister from time to time, and he's supposed to disagree with us. That's how we have ideas and create a better environment. But you can do it respectfully, and you can do it from a standpoint of trust and hearing, or you can do it from a standpoint of I'm right and you're wrong. And it seems in the last couple of years we've gotten more towards I'm right and you're wrong on a couple of issues, or less willingness to sit down and find common ground and language. And that's not the fault of anyone in Congress. That's certainly not the fault of the administration. It takes a lot of nurturing and a lot of time, and people have to spend the time and effort. Those bridges are not easy, but very much able to be built. And I know people are interested in doing them, and we just need to spend the time and effort on it. But we're going to have to begin by understanding there's going to be disagreement on some issues. Let's find where we agree and push that forward. Otherwise, the great things the minister is doing to save lives is going to be in jeopardy.
Yeah, may I add on that?
Please.
I think bipartisanship can actually be strengthened if we focus on the results that we have achieved. Many years ago, I think when people, especially the poor ones, didn't have access to HIV treatment, many were dying, in millions actually. And from zero access to treatment some years ago, now we're treating millions. And I think that result means a lot. I remember when they were diagnosed for HIV some years ago, they took it as if they're condemned to death. That's it. And now, when people are diagnosed with HIV, at least they know they can be treated. And there is hope in each individual. Means that hope could be a hope for the nation. And I think that should really tie us all together, not only in one country between two parties, but the whole globe even, because it's about humanity. And we have to be proud of what we have done, and we have to really build on that. And maybe another issue I would like to raise in relation to this is, of course, this result is because of solidarity. And solidarity even makes more sense when the times are very tough. Of course, the situation is very tough for the U.S., very tough for the many developed countries. We know how the situation is in terms of economic crisis. But it's even tougher when it comes to the developing countries, even tougher. So it's during tough times that we need solidarity. And I hope people will also understand this. But having said this, I would actually like to use this opportunity to thank the U.S. government, the U.S. people, and also throughout the developed country who have been supporting this important cause. And I hope this is not a time to downplay, but to even become more aggressive and express the real solidarity when the time is really tough. So I'm really optimistic that, as what Mark said, there should be always discussion. Maybe people can disagree, but at the end of the day, I hope we will decide the right thing. But we should also recognize that all the support that has been given is really incredible, especially in the past 10 years. And I hope we will not undermine that, and we will build on that and strengthen our solidarity, even during tougher times. Thank you.
So on that optimistic note, I have a bunch of more questions along the lines of reproductive health and family planning for women, and also about the Global Fund. But I also would like to turn it open to questions here. So if anyone, what I'd like you to do is we have mics on the floor. To introduce yourself, and if you're representing an organization, to name that. If there are any questions, raise your hand, and I'll call in. Okay, there's one over here. Anyway.
It sounds like it's working. Hello, I'm Dr. Mary Carnell from JSI. Just want to thank you all. But I have a question regarding the Global Health Initiative and global funds who are looking to see if they can broaden the vertical mechanisms for TB, malaria, and HIV to really carry MNCH, maternal newborn child health, and to without a lot more money coming into it. And to just ask you how you see that going and that struggle between the mortgage, if you will, that some see that we have for HIV and a lot of our money tied there, and how we can make systems more efficient to carry the maternal newborn child.
That's a great question. Does anyone else have a question? We'll take a couple right now.
Hi, my name is Jennifer Redner, and I'm here on behalf of the International Women's Health Coalition. Minister, I wanted to applaud Ethiopia for the incredible efforts that the government has undergone to address the issue of early enforced marriage. Really, it's a emblem that we hope many other countries will follow. I was hoping you could talk a little bit about how you see the issue of early enforced marriage undermining the effectiveness of global health programs and other U.S. foreign assistance that Ethiopia may be receiving, and also ways in which you see the U.S. being able to increase its support in addressing the issue of early enforced marriage in Ethiopia. Thank you.
Okay, let's take those two and see if we can get some fairly quick answers. Amy, do you want to start?
On the first, a great question about how do we really ensure that with these platforms we have through PEPFAR and PMI that we can build them out for some of the MCH and family planning types of programs. And I think there's a lot of scope. These are very strong platforms. They're very well resourced. And by adding maternal and child health into some of the PEPFAR platforms, what we're finding is we can actually deliver those services to the women and do it at relatively little additional cost. So in the case of Kenya, they've added MCH family planning services into the PEPFAR platform and have been able to go from 2 to having it out in all 8 regions at almost no additional cost. So really just using that system that was in place. I think what's particularly exciting is that while we're doing this, it's actually improving the services for your AIDS woman. So that not only are you being able to achieve other health outcomes, but you're doing it in a way that's actually improving your AIDS outcomes, improving your outcomes for both the woman, but then you're reducing stigma. You're increasing her demand of those services and so her willingness to come to the facilities and receive those services. So you're actually having a hugely beneficial effect while also achieving sort of broader sets of health outcomes. So there's a lot of scope, but it requires some creative thinking, and it requires looking at how we're approaching our delivery systems a bit differently, how we can integrate those services differently, and how we can kind of empower the various delivery mechanisms such as the community health worker or other platforms with new and better tools.
Mr. Tedros.
I would ask the person who asked the question actually to rephrase it a bit. I have understood part of it, but I want to be clear about the early marriage. Sorry. Thank you.
So Ethiopia in particular is considered to be a government that is trying very, very much so to address the issue, both at the community level and at the national level through laws and whatnot. Unfortunately, many countries that have high prevalence of child marriage are not as willing to address the issue, and so that is a challenge in and of itself. But in terms of the GHI and investments happening in Ethiopia, whether it be education or global health, the issue of early enforced marriage, as we know, does undermine these outcomes. And so just wanted, from a country-level perspective, how you see that impacting successes on the ground.
Mm-hmm. Okay, thank you. Thank you so much. By the way, as we have been saying, the direction should be to build on what we have been doing with PEPFAR. And that's exactly what we're doing now. And Ambassador Eric Gusby was in Addis in Ethiopia last week. And we discussed about, GHI and the way forward and so on. By the way, we have continued this candid dialogue, negotiation. And we try to tell our colleagues as much as possible, what we exactly need, straight talk like what John was saying. So we have continued to do that with, the new directors and including Ambassador Eric Gusby. and the meeting was very candid and very productive. And one of the things we have agreed is something that we have been discussing for some time, to have one plan under GHI, one implementation plan. Not to have this COP this year or COP this or USAID plan, CDC plan, and so on. All agencies come into one, and we develop only one implementation plan. And we're doing that, and we will finalize by May. So be it early marriage or anything, as far as we consider that it's our priority, we can include it. And that's what we have agreed, and by mid-May, the plan will be ready. But the interventions on early marriage, we don't believe are really capital intensive. This could be done easily through even local sources, using women's group to put, a lot of pressure on families who, force their children to marry at a very early age. And in Ethiopia, as you have rightly said, there is actually a law. But it's very difficult to enforce it because it has been a tradition and culture, for millennia. So it needs behavioral change, and that really takes time. And we're working with communities, with civil society groups, in order to really teach families and put pressure on each other, and to see the benefits, and to ensure from our side that our message is really getting through, not only directly from us, but through their own system and groupings and so on, and really looking for effective ways of communication. And that's really changing the tide, and I'm very hopeful that we will have significant move. But our phase depends more on how we really progress in expanding education in Ethiopia. As you know, primary enrollment is now the gross one, more than 93%. And especially until the grade 8, the number of boys and girls in school is the same, and in some instances even more girls. But when you go higher, you see less less girls attending schools. And when you go to the university, especially higher institutions, it's less. So we're really working on that, on how we can educate girls, because that's the most effective and strategic solution while trying to fight fire now. So we're using a combination of both, enforcing the law, education. Just for now, when I say education about talking to the communities, crafting effective messages to teach them on how this situation could really affect the child's health and so on. So the firefighting part of teaching now, and also using the women's group to put pressure, which is another firefighting. But we rely more on the strategic solution, which is educating girls. And the proportion has significantly changed, by the way. Even girls who are joining the university is very significantly different from what it used to be. And we're creating access also. In the past, we didn't have even enough universities. Still, of course, we don't have enough universities. But from 2 universities some years ago, now we have 31 universities in the country. The access is very important, while encouraging women or girls to have even higher education, but at the same time we need to increase its availability. And our government is really committed, and we hope that will address the problem in the long run, and we have better phase in that.
So since it's a straight talk, if I could just say 2 quick things on the first question. One is we really have to stop using things like treatment mortgage and entitlement. I know people are using them all the time. They have such a negative connotation. And we need to remember that every dollar of that mortgage or entitlement is actually saving someone's life. And that life is a mother 60% of the time, or a woman 60% of the time, who's keeping kids from being orphaned, who's keeping their kids fed, who's getting kids to clinics. I mean, we've got to stop using those terms that make it sound like this is some negative thing that we're burdened with. This is a, this is a very light burden that saves people's lives and is restructuring societies. That's not a mortgage. That's an opportunity. On the maternal child health thing, what GHI is trying to do in this is extraordinary, and we're so glad they're able to do it because we tried and it didn't work. It was in Ethiopia the first time I went to a beautiful, pristine PMT-CT clinic, perfectly well-trained, well-staffed, great lab. You walk through the doors and you're in a maternity ward. That's a disaster. For a tiny amount of money, you can expand that to have one site that's a maternal neonatal health clinic that would improve the lives of women and children. I can't tell you how hard we tried to get our colleagues to use incremental amounts of money to do that. It was impossible. I mean, we succeeded in a few places, but it was impossible. We have a new administration that can do things that we couldn't do for a variety of reasons. But I also caution that we need to be careful and respectful about political lines here. I mean, the social conservatives are the base of support for development in the Republican Party. You can look at the PEPFAR reauthorization vote. You can look at who spoke in favor of PEPFAR on the floor. And you can look at who's speaking now on the social conservatives are the base of support for development among the Republican Party. Now, there are some outliers to that, but that's really where it comes from. And so we need to ensure that there's voluntary family planning available for women who want it. But we can't alienate people who have conscious or other issues with that. And it's perfectly easy. You can actually manage all of this. This is an issue of administrative leadership and management and listening to people. It's when we don't listen and when we try to force things that we get into trouble. And this is all manageable, and if everyone in this room works together, we can solve these problems. If we all plant our flags in the ground and say, we're not going any further, and we're not going to talk about this, and we're not going to work on this, and we won this election, so we're going to do this, which we've heard from some groups, I would say less members, certainly not the administration. If we get past all that, we can actually solve all these problems, and we can make sure that the minister can do what he needs to do in a way that is not only sellable, but embraced by our political leadership from across the spectrum.
So great point, but can you give an example? Can you be explicit?
The family planning is an obvious one. I mean, family planning is a difficult issue, not because of family planning itself, but think 15 years ago, right? President Bush, H.W. Bush, and President George W. Bush were big supporters of family planning. President Bush said repeatedly that I'm a pro-life president. I will always be a pro-life president. One of the best ways to ensure there aren't abortions is to have family planning. We can reduce the number of abortions in low-income countries by 70%. We can reduce the complications with family planning. But then there were movements to basically say, well, you can't do family planning unless you include safe abortion. Well, we can have that discussion. I mean, I think that's a discussion that people from many fronts want to have. What's the value of safe abortion? Ethiopia has safe abortion. That's a decision the ministry made. But when you put these things together, you begin to lose political support. And when you draw battle lines, you begin to lose political support. So these are all very manageable issues if they're done in a respectful way, and if they're done in a way where we listen to each other, we find language that's manageable, and where we agree to say, look, we're just going to disagree on this for now. But let's do this because we can save a whole bunch of people's lives today, and we'll work on these other issues later. And by the way, if we do this common stuff, those other issues actually start to vanish pretty quickly because you're taking care of the needs of the women and children long before you get into problems that become politically difficult. And if we talk about things in a different way, and if we agree to disagree, but also talk in a respectful way, we can get over these issues, and we can solve these problems. But if we don't, we are in trouble. We are in serious trouble, and not just on women's health issues. We're in trouble for all of development, because the people who support development, if they get frustrated and angry and don't want to play, we're not going to see support for global health. We're not going to see it for the Global Fund. We're not going to see it for GHI. We're not going to see it for anything. So we all need to work together in a different way, back more to where we were able to do 7 or 8 years ago, not because uniquely to us, but because people were willing to do that, and we need to get back to that. And I think there's a real opportunity to do it. And we can do things we couldn't do before. We have so much more information. We have the results. We have new mechanisms to do efficiency and effectiveness. We can show that if you just extend that PMTCT clinic to maternal and neonatal health, you can save so many more lives. The same person who just delivered a child who's HIV positive won't die in childbirth. It doesn't help that mother or that child if you save her life with antiretroviral therapy and prevent the transmission, and she dies in delivery. This is not complicated stuff, but we have to do it in a way that is respectful and has an open dialogue and where we trust each other. And if we do that, we can overcome almost all these problems.
Okay, more questions. There, and here, and in the back. So three.
Tony Carroll of Manchester Trade, and I also teach at Johns Hopkins School of International Studies. Ato Tedros, one of the hidden stories here is Ethiopia is predicted to be the fastest growing economy in the developing world over the next 10 years. It's your evidence of the great vision and that your country is employed not only in health but also in other areas. However, with a growing middle class, there will be opportunities for the growth of the private health care delivery systems. We talked a little bit about the initiation of a health insurance scheme. I'd like to learn a little bit more about that. But I'd also like to see what has been the sort of the supply response from investors coming into Ethiopia and looking at investing in chronic disease care, diagnostic care, insurance schemes, and what have you. Because you have an enormously wealthy and capable diaspora, I think a great potential for not only technology transfer but investment going back into Ethiopia. So, and let me add my congratulations to your well-deserved award tomorrow evening.
Thanks. Any question right here? We'll take three questions.
Hello, I'm Selena Shokin from PSI. And my question is mostly about the Global Fund. And in the last few months, we've seen a fairly large media scandal, whether deserved or not. We've seen a launching of the Global Fund's reform agenda. And we're also facing a pretty serious budget crisis. And I'd like to know a little bit more about sort of the future of the Global Fund, particularly in this really difficult budget environment.
And in back there? Yeah.
I'm Folika Ojalabi from Nigeria, and I'm an international advocacy fellow with Population Action International. I'll thank the Ambassador Mark and the Ethiopian minister for their presentation. Ethiopia is similar to Nigeria in high fertility and high youth population. So my question is, what is Ethiopia putting in place as a strategy for maternal health supplies to prevent stockout and all of that so that Nigeria can also adopt that mechanism? Thank you.
So we have a lot of questions, so if we can be concise with the answers, would be great. You want to start?
Okay. Yeah, thank you so much. I think with regard to, I will start maybe with the Global Fund. The Global Fund is a very important mechanism, by the way, something that I have really a very strong phase, a model that's working well, and a model that has really helped the world, especially in the last 8 years, change the tide. When I refer to the millions of people on treatment, it's mainly Global Fund and PEPFAR funding. In Ethiopia, because of that model, this funding model, we have really made good progress in all three fronts: HIV, malaria, TB. And not only that, as I said earlier, we used the funding to build our health system. And I think this model is one of the most important ones, and I really thank the global leaders who started this good model in 2002. And then when it comes to the fraud and corruption, Global Fund has zero tolerance on fraud and corruption. And this can be seen easily from the steps that the Global Fund itself has taken. The media issue was actually late. A year ago, when it was first discovered, when we discovered the problem in some countries, it was Global Fund Inspectors General Office that identified the problem. And not only identified, but the Secretariat, based on that finding, took action very swiftly. And not only the Global Fund did that, but it communicated all the information to all relevant bodies. And this shows also the transparency of the Global Fund. And we want it to be that way because donors or partners can have trust on the Global Fund if we keep that transparency. And if we can keep that, we identify the problems ourselves and take action swiftly. And that, I think, will boost, or we expect that would boost faith and trust in Global Fund. Because people who want to put their money in something, they want to know whether this money is being used properly or not. And that's why we have zero tolerance on fraud and corruption. And we also uphold the principles of transparency. And we're even building more on that now. We're strengthening the local fund agents working in countries. And we're also expanding the responsibilities of CCM, country coordinating mechanisms, in order to have more oversight in addressing any problem that may happen. And also strengthening the financial arm of the Secretariat to even make it more stronger. Where there is risk, fiduciary risk, we need to address it. And also we have doubled the budget of the Inspector General in order to do more. But even since, as I said earlier, we say zero tolerance and we want even better transparency, we have put together a panel which is led by two very prominent people. As you know, one of the co-chairs is President Festus Mogae, the former president of Botswana, and also a former Minister of or Secretary of Health of the United States, Mike Leavitt. He was also former governor before he became minister. And this is also to assure to the world that we're committed to really top level, to high level of transparency and also zero tolerance to fraud and corruption. So what we have discovered so far, it's not really different from anything that you get in any organization. And we believe that from our transparency and all the things that are going on, we hope the donors' phase will be more even, assured, and we hope donors will continue to support the Global Fund. But since this is a straight talk, maybe one thing that I was really unhappy about and something that disappointed me was some countries have withheld their support. And this is like, making the Global Fund the victim of its own transparency. As I said earlier, you cannot eliminate fraud or corruption. You can only minimize it. And if the organization is transparent and trying action very swiftly and without any mercy, because it upholds that zero transparency, and you actually expect partners to really identify that as a strength and support that kind of organization. And you can ask why. I was also disappointed because, as I said earlier, this thing was open. We told the world a year ago that we had this problem. Not only we identified the problem, we also told the world that we have taken action. And all the process that really followed. And I think that should have passed really a positive message to all those who are supporting. And the reason for the disappointment was, although this was transparent and many of the partners who withheld knew about this, when we asked them why they did withheld, they said, of course, we knew about the situation and we were very happy that the Global Fund took action, but when this thing was in the media and triggered public debate, that's why we took this action. But I don't think this should be a reason to withhold funding, because if I were in that position, I would say I knew about this situation Global Fund itself discovered this problem, and it has taken a swift action. All the specific actions that were taken, people who were jailed or purged from their job, and then the other measures. And I would say it's in good hands, because when there is something bad, they take action, and when the money is also saving millions of lives, so they should have saved that instead of withholding. And the other problem is any action you take because of any specific situation has to be very specific, because we shouldn't penalize everybody because there is some problem somewhere. The problem that the action should be targeted to that specific situation. So we have really great results because of Global Fund, and when you penalize, when you impose blanket penalty, then you also affect your best results or your good results. So the action should be really specific. But as I said earlier, we also, this is our top priority, and we will do it that way. And I hope our panel will also take this to even a better or higher level to increase the trust of those who are supporting Global Fund. But from my side, I think we have to uphold the transparency. We have to really uphold the principles of zero tolerance. And at the same time, we have to continue supporting Global Fund. And it's still the best model and something that we can have phase in. Then going...
Just before you go on, just to say, I think that also the U.S. government is very supportive, recognizing the very, very important role that the Global Fund plays, an absolutely critical role to provide a forum where you can have all of the stakeholders coming together to jointly identify what are the priorities, what are the best strategies and ways forward, and how do we use the resources, how do we collectively decide the best way to use the resources to achieve these kind of goals. And has been working very, very closely with the Global Fund, both at the global level under Ambassador Goosby's leadership on the various reforms to strengthen the Global Fund's capacity to really be the optimal, the strongest entity it can be, but also at the country level. So in each of the countries where you have Global Fund resources, you also have the USG teams on the ground working very closely, helping ensure that the way the Global Fund and the way the U.S. government are working in that country are very complementary and are sort of supporting each other, so that ultimately the patients get the vaccine, get the drugs that they need in a timely way.
So for the two other questions, just to really quickly get to that, then we have maybe time for another question or two.
Okay. Yeah. As you rightly said, Ethiopia is now one of the fastest growing countries. And that's actually one of the incentives for me to get up and running every day. I see that, we're saying enough is enough. And the country is now on the right trajectory, and we're happy. And that's becoming really a great incentive to all of us. And with regard to the insurance, we are trying to introduce two types of health insurance, the social health insurance and community-based health insurance. The social health insurance is for the formal sector, be it in the public sector or the non-government or private. Those who are on payroll can join that type of health insurance. And then we have the community-based health insurance for the non-formal sector. The social health insurance is already a law now, and we're establishing now a new agency to run this, and we will introduce the new social health insurance by September, October this year. We will start it by then. The community-based health insurance is being piloted in certain districts, and once the result is compiled, we will do the analysis and put the best design for our country. But that will cover almost the whole country if we can introduce both social health insurance and community-based health insurance. With regard to the private sector, we're in contact with many people, as you rightly said, in the U.S. We have a big diaspora population, by the way, Ethiopian diaspora, and some have already started investing in Ethiopia. And there is a lot of incentive, actually, to give them a good start. And I would be happy if you can reach out some of the Ethiopians who would be willing to come to Ethiopia. Then on the high fertility, I think the high fertility, it's there. By the way, it's now going down in Ethiopia. It's really going down, and we're encouraged by that. But it's on voluntary basis. We don't really say to mothers, or we don't take it like a policy of must, taking a must. It's volunteer. And we have, of course, unmet need we need to cover, as the logistics that you have said. So we try to show the choices that a mother has, and then to also tell her the benefits. And then you have the choices, you have the benefits of, taking these family planning methods, whichever of your choice. Then it's up to her to choose whatever, based on, on our education or so. But from our data so far, I think family planning rate, the contraceptive acceptance rate is increasing, while unmet need is decreasing, and we hope that will decrease the fertility. But as I said earlier, it will all depend on the choice of the mother, and it's purely volunteer, and we want to keep it that way because it's up to the mother and up to the family with enough information that we can give them to choose whatever they want. And with that policy, I think it's changing, and we're on the right track, and we hope we want to build on that, to involve them, to empower them, but the choice will be theirs, and that's the policy we're trying to push.
Just one more question, if we could. This woman here.
Nandini Uman from the Center for Global Development. Welcome back, Minister Tedros. And we had the fortune of hosting an event on country ownership that Minister Tedros spoke at, and I think the whole news that you're doing a common implementation plan under the GHI is an exciting one and clearly country-led. And so I have a couple of questions, quick ones, that probably Amy and you would respond to. One is this a implementation plan that's going to be adopted by, not the same plan, but are all GHI plus countries going to do a common implementation plan and not go in the direction of a COP, which sounds then promising, because it's the second question that I want to ask, which is about the sort of opportunity to integrate beyond PMTCT for reproductive health, where you have many different funding streams coming in from the USG that are tied to results. So when you have separate results for dollars, how is this platform going to actually enable integration so that you do get integrated outcomes as opposed to reporting under these different budget lines? Thanks.
So on the, it is exciting to see the country ownership, and that the approach that's being taken in these GHI strategies, which started with 8+ countries but is now rolling to all countries that receive USG's investments in health. So we have the next 20 countries who will have their strategies coming out by end of June, and then all countries by end of December. And the process of developing those is with the government. It's based on the national plan. And then how can we help support the priorities that have been identified, the particular kind of challenges and strategies that have been identified to really to help to support moving those forward. The strategies are very high level. Okay, we knew we had already the AIDS operational plan. We already had the malaria operational plan. We already had, MCH operational plans. And the last thing we wanted to do to our country teams was say, start all over again with yet another set of operational plans. So what we've done is ask the teams to think about, based on what the national priorities are, what are the kind of cross-cutting issues that you haven't been able to really get at within these much more kind of vertical operational plans. So you have things like in the Ethiopia plan, much more focus on how do we help strengthen the actual outreach, the service delivery, which will ultimately support our HIV/AIDS goals and our malaria goals and our maternal child health and family planning goals. So you're getting more of those cross-cutting things. The expectation is that at least in the short term, that will get that the operational plans will start aligning. This becomes basically the roadmap, setting the direction as to what do we want to see in each of our operational areas. And each year, as the COP is sort of reworked and the next MOP comes forward, is making sure that those are aligning, that those activities identified are aligning more and more tightly to that GHI strategy and what was identified with country partners. In the long term, what we really would like to see is, as Minister Tedros was saying, is one plan, one development plan, and then within that, one sectoral plan, which includes, the trade-off between all of these priorities, and then how we go at the HIV/AIDS piece, and the malaria, and the integration, and all the rest of it. As you identify, the funding streams are a challenge, but that's something that it's extremely important for us to be able to report back to the Hill how the money they've allocated for these different elements is used, and what are the results that come out of those resources. But as I was saying, we're finding that, for example, by bringing MCH services in this PEP4 platform, we're actually able to help increase the HIV/AIDS goals, because now you have more women coming to the facility. There's less risk of stigma. They're getting all of their needs met. So more of your HIV/AIDS targets are being achieved at the same time as you're treating the whole woman and all of her needs. So I think we're finding ways to make sure that we are absolutely faithful to the intent of the Hill on the kind of resources that they've allocated, at the same time as achieving those goals plus more.
Yeah, thank you. To maybe add on that, I think the implementation plan is now being developed based on our Health Sector Development Program 4. And as what Mark said when he initiated, we're just keeping that up. Based on our priorities, we develop the implementation plan. Then when you do that, even if you go to the specific areas like PMTCT, it could also be our priority. If it's not our priority, we tell them, no, this is not our priority. Please, thank you. Let's do this. But if they want specific things like PMTCT, and that's our wish, then we can keep it. For instance, in Ethiopia, we're happy to keep PMTCT specifically. And we're happy to keep, institution-based delivery for mothers specifically. And we want to keep case detection rate for TB specifically, because our coverage is really not good in all these three areas. We have identified that. And where we have a problem, we ourselves want to pinpoint and put it concretely that, this should be specific in order to give more resources to that and make a difference. So PMTCT, as you rightly mentioned, is actually specifically put in our implementation plan. And because our PMTCT coverage is poor now. So, based on the priorities we want to focus, we can make it specific even without the request from our partners. And when there is a request for something which is not our priority, we say, no, this is not our priority, so let's get into dialogue on how to really handle that. And we can shape up, the whole document in the process. Thank you.
I just want to say one thing on that, because you touched on a pet peeve of mine that's implicit in your question, which we hear all the time, is that somehow with integration we lose control of the money and you don't know what results you're getting. That's absolute nonsense. What you care about is the health of a person. When the minister looks at his health programs, he doesn't just look at, he's still going to follow, even though he's delivering care to a woman and a child, whether or not vaccines are occurring, whether or not maternity mortality is going down, whether or not child mortality is going down, whether or not PMTCT rates are. You still have the indicators. You're just delivering the services in a way that's more sensible, that's focused on saving the lives of a person and creating a happy, healthy family. That doesn't have to get in the way of budget lines. It's just a management issue of how you manage those budget lines, and also being sensitive to the political realities about some of those. So you actually, as Amy said, get better results. But there's this notion that we hear all the time when people are talking about expanding the global fund or anything else that, if you integrate and you try to do more than one thing, it's impossible to report on results. It's absolute nonsense. The opposite is actually the case. And to be honest, it reminds me of the early days of PEPFAR. When President Bush put forward those aggressive goals, John maybe remembers, maybe others, we were criticized roundly for setting goals and targets because development was too complicated to have goals, that you should just give money and see what happens. results-based development is how we're going to get resources. Results-based development is how we're going to save lives. And we can do better for people and get better results and report with better indicators if we deliver services that are targeted to delivering happy, healthy families, not tackling a disease. So we just need to get, it's like mortgages. We need to get rid of that notion that integrated services somehow means you can't track the money.
So on that note, it's a little straight talk.
Good. Thank you so much, panelists. That was a wonderful conversation, and thanks to all of you for coming. I think there's a few takeaways that I have, and I really just want to thank you for modeling this notion of give and take between donors and countries. It's really quite refreshing. And John, thank you for forcing people to tell their stories and to talk straight. I think there's a few key takeaways. The notion of one plan, one way forward. The notion of the integration that is also results-based is a key finding, and there are many others we heard today. I just want to, again, give a round of applause to our panelists who are wonderful today. To say that the next Roundtable series, we have a Roundtable series called 7 Billion, Conversations That Matter. This year the population will reach 7 billion. And we will have Congressman Dan Glickman speaking about food security and population on April 12th. So we'd love to have all of you. We hope you're on our mailing list. And please look forward to seeing you again and to picking up materials if you want on the way out. Thank you.